How many people here see people with low back problems? It's challenging, isn't it? It's an endless cycle, you know? There's such a vulnerable area, you know? And I know as a chiropractor, it was like, low back, it's like, I don't know. If they cough or sneeze or, look at someone the wrong way, their back's going to go out. It's like one of those things. Well, back going out, that's a very interesting concept. Think about it. Where did it go? Did it go out for drinks? Did it go out to the movies? It's like, and the idea of a joint going out of place, that idea that I was taught in chiropractic school, it's like, really? It's like, you have a close look sometimes. I taught human dissection for 3 years, and you look at the massive amounts of ligaments and muscle supporting the pelvis and low back and the sacroiliac joint, and it's not going anywhere, right? There's no way of going out, right? These paraspinal muscles, which include the rotatories and the multifidi, in my opinion, are neuromuscular ligaments. They are monitoring and regulating moment by moment relative vertebral position for a very important reason. Their role is to protect the spinal cord, all right? So they limit and manage vertebral motion in a very powerful way. They have massive numbers of motor units per unit muscle, okay, in terms of neuromuscular control. So they are kinesthetic receptors and regulators of position and movement to prevent damage to the spinal cord. So when you bend and twist, it's never just pure bending and twisting. It's always a coupled motion. You understand this concept? Chiropractors were taught this. I don't know if anyone else understands that, but there's this concept of coupled motion. When you side bend, there's also rotational components to basically maintain the integrity of the spinal canal. The spinal canal is protected at all costs. So this relative movement and rotational side bending motion that's combined is designed for the purpose of protecting the spinal cord. So there's no deformation, no mechanical stress, or it's minimized, okay? So that is the main purpose of the spine. It's an amazing structure, which is, the design is beyond belief, but its role is to protect the spinal cord at all costs. So one thing we need to remember, why, if the spine is so protected, okay, what the hell is happening down here with the low back? Why isn't that protected? Why does this thing break down all the time? So can anyone tell me about the spinal cord? Where does it begin and end? Yeah, so it ends around anywhere from L1 to L3, maybe. Some people are a little shorter, some people are longer, okay? But the cord, there is no spinal cord down here, okay? You have the cauda equina, which is individually myelinated nerve tracts, which are much more intrinsically less vulnerable than the spinal cord. The spinal cord does not have that hypermyelinated component to protect it on its own. The body will literally sacrifice this area to protect here, higher up, okay? That's what my conclusion is based on what I found with stability issues, okay? So when I look at these paraspinal muscles, so we talk about, testing the stability of the low back, the spring test, is all these things. It's a challenge, okay? But you can feel, and the patient can feel, muscle tone, okay? So that's all you need to think about. So if I go into his paraspinal area, here's the spinous process. That's where I'm palpating, literally just a ½ inch over on both sides. And I'm going to go straight in towards the spine, and I'm palpating, and Albert can feel the tone there. And as I start to get down here, we get into some issues here. Okay, do you notice what's happening to these muscles, Albert? Compared to up here. Can you feel the tone there? Right? And just relax and just feel the tone here. Okay, can you see what's happening? Yeah, what's happening to these? It's mushy down. Very mushy. Okay, so this is a significant thing. And who hasn't been up here wants to palpate this? What's your name, young lady? Yes. Lynn, come on up here. So I want you to palpate starting here, right? Just nice and easy. Just feel the tone, okay? And keep going down and see how that feels. Just go straight in. You don't have to, don't have to massage. Just kind of feel. You see what happens as you get down there?
Testing joint play.
I know, but yeah, I know. You're just, I knew what you were doing. Yeah, try. Yeah, you can do that too. But I want you to just do the muscle for now. Really simple, because he can feel that. Yeah, just go straight in. Don't go up. Straight in. Real simple. Real simple. You're kind of gliding up. I want you to go straight in, but not hard. Not hard. No. Just you. Here's the thing, guys. If you palpate hard, you lose huge amounts of sensitivity in your fingers. Okay? When you palpate hard, feel that. Just feel that. And wait, slow it down. Ease it. Just feel the tone. Feel that tone. Feel that. And now go lighter and just feel it. Just drops away. Can you feel that? Yeah. Just mush. Right? Keep going down and see how far down that extends. Right? Nice and easy. Feel it? Okay. Got that sense of how mushy it is? Right in there. Got it? Nice and mushy? Good. And just wait for it. Okay? Now just relax your fingers. Here, watch what I'm doing now. I'm placing these here and here. Okay, so I want you to feel what happens.
It's increased tone.
Increased tone. Okay? Can you feel the difference? Yeah, increased tone. Literally turns it on. Okay? Lots of increased tone. Now, I'm going to turn off the machine. Stay there. Okay? I'm turning it off. Give it a second. All right, now wait. Okay, now test it again. What happens?
Mush again.
Mushy, like that. Okay? Thank you. Lynn?
Thank you.
Okay. All right, thank you, Albert. You can get up. All right, this is something you guys will be able to feel as a practitioner and a patient. When you are able to demonstrate that, even before you treat those areas, do you think it's going to be tough to convince someone with low back issue that you have to fix their pelvis or their rib cage in order to fix their low back? Albert, do you think you need a lot of convincing?
You fix me now.
Not yet, but you know that I can. That's the point, okay? The point is you are going to be able to demonstrate this even before you treat. You're not going to have to sell anyone. Oh, you got to come back for like 10 treatments and it's going to take this long. No. You're going to be able to show them what you can do even before you do it. And you're going to say, it's not going to take that long. It might take 2 or 3 sessions, all right, to get all these little components, all right, when you get good. But it's a done deal. They already know where they're going. They already know that their low back is going to improve stability. And anyone who has low back issues, and you tell them you're going to stabilize it in order to allow that tissue to heal, it makes sense to them. Because they know if they twist the wrong way, the way it is now, they twist the wrong way, they bend over and pick up their toddler or something, or, cough or sneeze or have a bad coughing fit, their back might go out, right? So they know that stabilizing is a really big thing. And when you demonstrate that instability and the fact that you can turn that stability back on, it's huge, all right? So that comes, it's relevant to the low back, okay? It's also relevant to the knee. Several other joints, the hip and the shoulder also seem to be a big factor when it comes to these issues with the sacrificial joints, okay? And discovering where they're coming from and being able to demonstrate that is a significant breakthrough in terms of our ability to help people understand their body, and also for you to be able to monitor the improvement. Because even when you stabilize it, is his back going to heal overnight? No. It's got inflammation. It's got tissue breakdown. It may have some disc bulging. It may have other kinds of stenosis and all these other things that have developed over time. But if you don't stabilize it, those can never heal. They will continue to break down. Okay, you may give them temporary relief, but it's going to keep coming back. I guarantee you that. Well, other techniques to stabilize the back braces. People are using things like prolotherapy. Oh, I cringe. So, and they're doing surgeries like fusions and things like that. We all know the outcomes with those. They're not great. They're not great. But they're all recognizing the need to stabilize, isn't it? These are, people have recognized the low back is unstable. Right? They've done everything. They're standing on their heads doing cartwheels trying to stabilize, and it's really short-lived. And even with fusions, within 2 years, that becomes unstable again. The body will fight. That's huge amounts of forces here. The body is generating, and the fusion will not last. It'll start to break down and form pseudo joints. Okay, so here's the thing. You can manage a condition. Absolutely, you're right. This is a very good question. Huge. Through exercise, you can manage a condition. And you still exercise, you still have to do it on a regular basis, or else you're in trouble.
Yep.
Exactly. Okay. So this is the thing with exercise, and a lot of people who do it, you do what you have to do to survive, right? So this is significant. So exercise will recruit other muscles to take over that role. And if you strengthen them enough, you may be able, this is the whole idea of core stabilization. You know, you've all heard about this. This is very big out there. But the thing is, if you don't do it on a consistent, regular basis, if you don't do your McKenzie protocols on a regular basis, people know that there's going to be a problem, okay? So here we are again. We're back in the low back area, and I'm going to test her paraspinal muscles, okay? So nice and strong. She's been working hard. They are unbelievably toned. Like, they are so strong, right? Mm-hmm. Yeah. Good. Beautiful. You've done a great job, but what happened? You didn't exercise down here. You were so good. Oh, what happened? Anyways, so you see when I go deep into there, Marianne? Yeah. Yeah, feel that? It's mush. Mush, L4-5, mush, right? Here, she's like a Olympic weightlifter up here, and here she's like, you know, the 90-pound weakling. Okay, so the point is, so if I locate this now, so you agree, it's mushy, okay? So, and she is doing her darndest to get the other muscles to work for that, but guess what? The light switch is turned off. Light switch is turned off, okay? Okay. So I'm going to do a quick and dirty scan here with you. Okay. Yeah, she's got an issue here on her left side. Okay, did that show up in the scan when people were? Yesterday, someone else found that. See, I'm talking to you about intertester. This is reliability, okay? You guys are going to see this. When you start doing this, this is objective, reproducible, and intertester reliable stuff, okay? And when we do the clinical training, we blind, you're blinded to what the other practitioner finds with the patient. Okay, so we really test it out. So you develop the confidence because you know what you're finding is real. Okay, so she has two big issues here. All right, one in her left pelvis, one thoracolumbar. Very common combination, isn't it? You know, do you think you might have fallen on your hip at one time in your life?
I like to rollerblade.
She likes to rollerblade.
I like to fall.
Yeah. Okay. Right, and you can feel when I go in there, right? Feel that compared to that?
Yeah.
Yeah. Yeah, she can feel that left side. She's really injured it. Okay, so we have, I'm gonna take the machine. This is why this is so handy. The magnets also help to some extent. I'm gonna turn it off, okay? Now I'm gonna place it in the thoracolumbar area. She's dead center because a lot of stuff going right across. And I'm gonna place the other one on her, I'm putting it actually under her sweater right here, okay? So it's sitting here on her left hip, all right? So I just keep using the sweater to keep it in place. The machine is off. Okay, good tone, and right here, getting pretty mushy, right? All right. I don't want to get mushy about this, but this is mushy. Okay. So the worst spot is right about there, about L4-5. Okay? Good, just relax. That's good. Okay, so there, you can feel that. You see the movement? I'm going in, right? So now I'm keeping a thumb there. Do you know why I'm keeping a thumb there? Landmark, and she knows I haven't moved it. Okay, so she knows this is actually something that is, you know, consistent, relatively consistent. Got the machine turned on. So now I'm going back to the exact same spot. Okay, what happened? Oh my, that was her words, not mine. Oh my. Okay, right there. Now I'm going to turn it off. I'm going to turn it off. Okay. Oh my. Mush. Okay, now, so Marian, you can sit up. So now, going back to what you wanted to say, what do you think now?
Oh, I definitely notice the difference.
A little bit of paper here on your face.
I have stuff to
There you
do
go.
somewhere.
Yeah.
But
Swing
but I
there.
can see that if
Yeah.
you combine these things, the exercise with this kind of work, then you really can create a.
And the good news is, if you didn't want to exercise, you wouldn't have to. You could just go for your walks and play tennis and have fun. Okay? You know what I'm saying? You don't have to do something to compensate for something that's not working. Once you fix it, you don't have to compensate anymore. You've done your darndest, and you've done a great job. But now you can see why it's limited. Yeah. So you're pretty clear now, right? If you were a prospective patient, which now you obviously will be, that there's more to it, and there's more that could be done to prevent it from coming back. Right. Okay? So it didn't take a lot of convincing. She was pretty clear. Her exercises were doing a great job, and they were. Okay? She is like a power lifter when it comes to her paraspinal muscles, except for where they don't work, where they're turned off, the light switch is off. Okay? Make sense? This, I believe, is neuromuscular. It's a reflex so far unidentified. Okay? I call it the ASR. ASR. It's in those notes. So that is the articular stabilization reflex, okay? And I believe it to be something that we have so far not fully identified, something that I discovered clinically in terms of being able to turn stabilizers on and off by influencing a primary somewhere else in the body, okay? The key muscles so far that we've identified in this, in the knee, it's the medial hamstring, semimembranosus, semitendinosus, the popliteus, all right, for the knee. The the paraspinal muscles in the lower lumbar spine. Third, we have the supraspinatus, which I talked about briefly yesterday, for the shoulder. We also believe there's a significant one in the hip and pelvis, which is the gluteus minimus medius. Parts of gluteus minimus, parts of gluteus medius seem to be involved in this. And you'll see inability or instability supporting the body on one leg at a time. You'll feel the tone difference. And the patients can feel the tone difference, and they'll notice when they're having trouble stabilizing over their stance leg. As well, you see the Trendelenburg kind of gait with these people. You'll immediately be able to correct that, okay? So those are the main ones we've discovered so far. There may be ones in the wrist and ankle too we haven't fully clarified, okay? But these are the ways I believe the body is protecting itself. This is I call it sacrificial joints for a reason, and that is the body is sacrificing something that's less vital to its survival in order to protect something that's more vital. Namely, I would say, the core structures like the spinal cord. This is protected at all costs. Because instability results in tissue stress, which can cause a breakdown of that joint. So where do we see most arthritic changes in the case of functional arthritis? The knees, the low back, the shoulders. These are surgeries that are rampant, okay? Guess what you can do now? You know, if you restore joint stability, imagine what can happen. The reality is we're dealing with things that people aren't looking at. They're not understanding that these things are happening for reasons that they're not looking at, because they're not looking at the entire, how the body interacts with these areas. And this mechanism, this articular stability reflex, is something that no one else has considered before. But you're seeing it. You're able to demonstrate it to yourself, and you're able to demonstrate it to your patient, which is very important because they are looking for a solution oriented around the area of symptoms. But in many cases, that area of symptoms is a reaction to something else that the body is recognizing. And when you speak the language of the body, then what you're doing is you're getting information that the body is trying to convey more clearly. All right? So this is the interface that we have here, the opportunity. All right? Okay? That's good. So that means you're going to help a lot more people, aren't you? All right?